This is the breakout on the integrated health homes, integrated behavioral health homes, excuse me. Let me get it right. And Alice isn't even here to correct me. So I've already introduced Chuck Ingoglia this morning. I think many of you heard my introduction of him. And Chuck has been, at least this is the rumor, so you can tell me if it's not true. The rumor is that Chuck has been very involved in the development of the CCBHCs in Washington, D.C. So I think we're really fortunate to have him here to talk about integrated behavioral health homes. So I'm going to turn this over to you, Chuck, and then we'll go to Marvin. And does anyone here not know Marv? I think everyone knows him, so.
And everyone's glad to know.
That's right.
All right.
So you're up.
So we had some discussion this morning around integrated care, and then Dr. Manderscheid in his comments talked about Section 2703 health homes, which was a provision, that's the section of the Affordable Care Act that created this new state plan option in the Medicaid program for health homes. And health homes, as we know, right, are not physical locations, but they're a conceptual way to think about the organization of care that is more integrated. So I want to talk a little bit just about integration generally. I think Dr. Southard will talk more about kind of California's approach to health homes. And then what I'm really looking forward to is dialogue with you, hearing your questions and then kind of concerns around this general topic. So when we talk about integrated care, I think what I like to keep in mind is or maybe ask you to think about, what do you personally want from the healthcare system, right? Have you had overwhelmingly positive experiences with the healthcare system? Has it been kind of mixed? What would make it better? Ask you to think about that for a second. I think most of us would say we'd like more communication between us and our provider, between providers themselves, so that they actually know what's going on. We'd like information to flow. We'd like somebody else to be managing that process and not us when we're faced with an illness or multiple illnesses, or not us on behalf of a loved one as we're trying to support that person and that person is trying to navigate the healthcare system. And I'd like just you to think about some of those kind of concepts as we think about this. And the other thing that I'd want you to think about, and how this all fits together, if we think about policy from 30,000 feet and how it translates down, is what's kind of the goal of health reform? Reduce costs, better patient experience, and but better quality, right? So it's not just about reducing how much we spend, but it's trying to also improve the quality of care, and then to increase the patient experience of care. What is it like to be a person navigating this system? And I don't have with me today, but you can look at some really interesting charts that look globally at health and healthcare spending, and then outcomes for kind of common indicators of health, things like premature death, babies born prematurely, et cetera. And you guys have all seen these charts before, right? U.S., we spend the most on health care, and we have low quality scores compared to many other countries. And so the idea here is, that was kind of brought forward in many state level reforms and kind of codified in health reform was, there's got to be different ways for us to think about how we organize and finance care. And certainly a theme within many of these different approaches is this idea of doing a better job of integrating care for people. And so and how does this touch us, right? We know that many of the patients we serve don't come to us just with a mental health or a substance use disorder. They bring with them chronic health conditions. And for many years, our system did not do a good job of identifying or intervening for those health conditions. And that would be okay if these people also had a routine source of primary care. But unfortunately, for many poor people, there's not a lot of physicians or practices that take Medicaid. And then you add mental illness or substance use on top of that, these become not very attractive people, to serve in a practice. And then conversely, right, we know that people who have heart disease, diabetes, cancer, have higher rates of depression and anxiety. Wouldn't most of us, right, if we were living with these chronic health conditions? And so, we have an opportunity because of our experience to do something different, but it's going to require some changes. So I think we all as we think about the future, it's not going to work for our system to be totally separate from the rest of healthcare. And certainly there has been movement over the last 20 years to build behavioral health capacity into primary care settings. And initially it was, well, if we just screen, that will be okay, right? And so there were lots of efforts 20 years ago just to screen for depression in primary care. And we realized that that was necessary, but not sufficient. And then models have developed this collaborative care model, which now has over 80 randomized controlled trials that says it's not just that you screen, that you have to do interventions for that person on site, and that physician probably needs some consultation from psychiatry over time to make sure that the treatment regimen is correct and/or a referral to specialty care. I think we have the same experience with SBIRT, screening, brief intervention, referral to treatment for substance use. It's evidence-based for alcohol disorders, yet it's very rarely implemented. And I think it's very rarely implemented for the same reasons that practices didn't want to initially screen for depression, is because they don't know what to do if you say yes, right? And so there's a lot of work to try to improve that end of it. And conversely, I think the report that was released in 2006 showing premature mortality and excess morbidity for people with serious mental illness based on their constellation of chronic health conditions was a wake up to our field to do something about co-locating primary care within behavioral health settings. So Sandra mentioned, our work around certified community behavioral health clinics and the Excellence Act, and I'll talk about that in a minute. But certainly before that, the National Council was intimately involved in establishing the primary care behavioral health integration grant program that's now at SAMHSA. And I think a press release just went out today about 60 new grantees from that program. But again, that was our very practical way of saying, all right, we know that people are dying. What can we concretely do to try to make this better? And let's try to then bring primary care capacity into behavioral health settings. And that was not, when we shopped that idea to SAMHSA initially. Now, I have to say, there were different people at SAMHSA than there are now. But when we said to the idea, why don't we co-locate primary care in behavioral health settings, the answer was not an enthusiastic, that's a great idea. It was, why would we do that? We don't need community behavioral health organizations building surgery wings. And we said, I don't think anybody here suggested that we build surgery wings, but how about that we monitor basic things and have primary care on site for people who need it? That doesn't seem too radical to me, and that program has endured for many years because of that. I think the other program that we were very involved in creating was the Section 2703 health homes. If you look at the original concept that appeared in the Senate Finance Committee bill, it looks an awful lot like a piece of legislation that Senator Stabenow introduced for us, creating this model. Now, well, the interesting thing is when the Finance Committee took a look at it and then included it in their draft, they made two significant changes to it that we didn't like. One was it no longer specifically targeted people with behavioral health conditions, and it no longer listed behavioral health organizations as eligible health home providers. So luckily we had amendments offered in the Senate Finance Committee that were approved that corrected that. So now we have this new state plan option. It's not a waiver, it's a state plan option available to states to create integrated care approaches for people with multiple chronic conditions. People either who have two chronic conditions, have one or at risk of another, or the criteria are very interesting, or if you just have a serious mental illness. So, I think they recognize that the risk factors associated with serious mental illness, were enough to allow those populations to be included. So, since the passage of the health home, 19 states have implemented health home models. And now it's interesting, 19 states, but they have a total of 26 state plan amendments amongst them. Because what you can do is you can target different populations in a state plan amendment. So Missouri initially had one state plan amendment that was focused on their community mental health centers. They had another one that was focused on FQHCs, and then several years later they did a state plan amendment to focus on kids who had trauma and were in the foster care system. So they did 3 different ones. Other states have done similar things where they have multiple state plan amendments. And we've seen now several states that have focused on substance use disorder. And what's the concept around health homes? That there are specified services around care coordination for people with these chronic conditions that include social supports and span behavioral health and primary care. So the idea here is that a behavioral health organization has been doing care coordination or care management for people with serious mental illness and really focused on their recovery goals, focused on their employment, their housing, but maybe never asked them about their health conditions and never coordinated care between their specialty behavioral health organization and primary care. And this is now what you would be doing in a health home is that care coordination activity would extend to other kinds of providers beyond behavioral health. So since this program has been implemented, we've been doing technical assistance to providers in New York and in Ohio. And also we run the Technical Assistance Center for the SAMHSA program. So I wanted to just reflect on some of the key elements that we think are important for making these kinds of approaches work. Globally, you want to have financial incentives that work for all parts of the system. And, I think one of the challenges we sometimes have is that so FQHCs, right, have an all-inclusive payment rate, and if you have an eligible encounter, no matter how long that encounter is, you get paid the same rate. So if you're a person with serious mental illness who's not had an ongoing source of primary care in 20 years, and you're a little unorganized, maybe have some other kind of issues going on, is your primary care visit going to be 7 minutes? Not likely, right? But that primary care, that FQHC gets paid the same amount whether that visit is 7 minutes, whether it's 30 minutes, or whether it's 60 minutes. And that sometimes creates some tension in some of these arrangements. Even if people have the best of intentions of wanting to work cooperatively, at the end of the day, it's got to work financially. I would also say that in health homes, the potential incentive, so the way the state plan option is set up is that your state has a lot of flexibility about how it pays for those health home activities. It could do so in a per member per month kind of way. It could do so in a fee-for-service way. And it has the option of doing kind of quality bonuses. But it's interesting, none of the states that have done state plan amendments have included some kind of performance bonus associated with that. People have been scared to do that. Also, you're being measured on, are you reducing emergency room usage, nursing home placements, hospital admissions, but there is no requirement, there's no skin in those hospitals and nursing homes don't have any skin in the game. And it's interesting, for several years I was reading all of the state plan amendments that states were submitting to SAMHSA, and they were really kind of humorous, because they'd say things like, hospitals will communicate with community providers upon admission of Medicaid beneficiaries. And I would laugh. And I would write in the margin, how? Why? Right? Because what incentive is there to the hospital? They're going to get paid one way or the other. So those are nice concepts. Those are important details, but they just don't happen automatically. Or in some states that have managed care, the idea is that the managed care plans have all of this data and they will magically make it available to providers so that providers understand the total usage of healthcare services for those beneficiaries. And magically, when it doesn't work, state officials scratch their head and say, what do you mean they don't just do that, right? So these are important things, but it's a part about kind of making sure that incentives are aligned and it goes to real-time information sharing. I think Missouri is frequently touted as the most successful health home, and I happen to think that it is, but it's not because of what they did when they got their Section 2703 Health Home State Plan Amendment approved. It's because they had many iterations along the way leading up to this, and they had built a clinical and data infrastructure that supported integrated care. They had trained staff in what it means to provide integrated care. They had data informatics available to every one of the care managers, so the care managers knew all the healthcare providers that person was, so they had access to Medicaid, they have access to Medicaid claims data. So they see not only what prescriptions are being written, which ones are being filled. They can see not just who that person's physician is, but did they actually go see that physician or that specialist. Missouri has a system where all Medicaid paid hospitalizations, no matter what the reason, have to be prior authorized. And then that then triggers an email that goes immediately to the health home saying one of your enrollees was just admitted to the hospital, you need to get over there and begin doing transition planning so that when that person is discharged, you can pick up with them automatically. So these things are possible, they just don't happen automatically. And I think Maryland and Michigan and Kansas have all implemented health homes. They did not have the data infrastructure at the initiation, but they have subsequently built that because they realized you can't do care management that includes behavioral health and physical health and it be data free. You actually have to have some information to guide the work that you're doing. So these are things that I think are important. We hear a lot about the idea of interdisciplinary care teams. So one of the things that Missouri did is they've trained all of their care managers, who are like your caseworkers, to understand the common physical disorders that people with mental illness confront. What do blood pressure readings mean? What's a good reading? What's a bad reading? what medicines are usually given for blood pressure, what's a good blood glucose level for a person with diabetes, what are the common medications given for diabetes, so that when the care manager sees this information, it actually means something to them, and it's not just a bunch of letters and numbers on a piece of paper, but they actually have some context for it. But then they also hired nurse care managers who were available as a resource to all of those care managers to answer questions for them. So those nurse care managers aren't seeing patients directly, but they're a source of training and consultation and support to the care managers who are doing the interventions with the individual clients. Now, Ohio, in their health home, they had made each of the health homes hire physicians to perform that function. It was a total waste of money and not an efficient use of resources. Nurses are eminently capable of doing it and easier to find. I know that's kind of laughable. I mean, there's a shortage of nurses, there's a shortage of doctors, but it worked just as well. This notion of high-performing provider networks also then refers to how do we have common skin in the game? I talked a little bit about that, and how is information flowing? I think there's a lot of hope that interoperable health information technology will be here someday. It's more of a hope still than a reality in most parts of the world. But you've got to find ways, workarounds to that. So we have organizations who fax and still fax, but at least they're communicating back and forth. Some clinics the physicians are texting each other. Now, I'm not a HIPAA compliance person, so I'm not going to tell you if that's HIPAA compliant or not, but that they have found different workarounds so that they can be offering information to each other. And sometimes people even do online patient registries. So if their EHRs can't talk to each other, they find other ways to share information back and forth. And I think the other thing that, if I reflect on the Missouri experience, is they have continued to invest a lot of resources in ongoing staff training and development. It wasn't like the first year we did training, we solved all our training needs, and then we moved on. That they're continually looking at the data, they're looking at the individual performance of different health homes, of different care managers, and then doing ongoing training to try to bring the entire system up. And I think that's also what's made them unique. We provided, I'm not going to say which state, we provided technical assistance in a state that was doing health homes. Behavioral health organizations were certified. Some of them were a year into being a health home, and we sit down with staff and say, what are you doing around health goals for clients? And they looked at us and said, what? That somehow the CEO had decided that their organization was going to be a health home, but that message had never really kind of translated down to the staff. They hadn't really built a culture that was accountable or oriented towards that. So I think that's also something that you want to think about, is how is this embedded and reinforced throughout the organization? And to step away from health homes for a minute, if we look at the primary care behavioral health integration program, we had that same experience where sites would do things like they'd organize this partnership with an FQHC, or they'd hire a primary care physician and some nurses, they'd open up a clinic in their office, and then the staff sat there because nobody was getting referred. And it's because they never talked to the care managers who said, this is a part of what you need to be doing at initiation. You need to be asking your people if they have an ongoing source of primary care and making internal referrals to that service. So I think they felt like Kevin Costner, if we build it, they will come. And they realized that it took a little bit more than that. All right. I think the other reality we've got to face is that there is a lot of hope and a lot of grant money that is going into integrated care, but the reality is we don't have ongoing sources of financing for integrated care. So I still feel like we're in this, it's like a leap of faith, that this is the right thing to do, but it's not like it is easy to finance over time. I talked about collaborative care earlier, which is the evidence-based model for doing depression and anxiety treatment and other kinds of interventions in primary care. That model still is not able to be financed in either Medicare, Medicaid, or in private health insurance. So even though we have 80 randomized controlled trials, that's a great thing. We know it's an effective approach, but there's no sustainable way to finance it. If you look at the PBHCI grantees, or even in states that were health homes, they were not necessarily able to sustain that activity over time. Again, if I think about, I hate to always talk about Missouri, but they were very smart about how they programmed that 90% extra FMAP. It wasn't used to, all right, we're going to stop doing this over here. Rhode Island and New York, who took their targeted case management money and said, oh, that's now a health home activity, and we're going to go from 50% FMAP to 90% FMAP. And then at the end of 2 years, when that money ran out, they said, what do we do now? Right? And it was very clear that they were trying to get some extra money. They weren't necessarily thinking about a fundamental shift in how they operate and what they're committed to. So I think those are other things I'm sure you have thought about on the eve of implementation. So we'll let Marv go, and then we can take questions later, but I'm looking forward to some dialogue with you. Thank you. I am.
Oh, good. Thank you.
You didn't even have to ask. There we go.
So my intention will be to be brief, although sometimes I get carried away, because I think the most valuable thing for us is to have a dialogue on this topic, because it, as Chuck was indicating, it is I believe the thing that we need to do most, but it is also something that I don't think anybody knows how to do well. I want to illustrate that issue about that it's important and that it's really hard to do from my own personal experience. When my mom was ill, my sister, who is a very, shall I say, assertive person, was in charge of trying to integrate her primary care with all the specialty care that she needed. And despite her intention and her vigor and her energy, it was a really hard thing for her to get done in a constructive way. For me, I have a very good health coverage right now, and I injured my back a while back, and so I went to my primary care doctor. He referred me to a physical therapist, but he actually referred me to 2 physical therapists, one for my neck and one for my shoulder. The guy from my shoulder said, I can't see you if it's for your neck, because that's somebody else's responsibility, and if something went wrong, I'd be in trouble. I went to the one from the neck, and he couldn't see me because of the shoulder. So I had to go back to my primary care physician to straighten out the referrals, but before they got straightened out, the back pain went away. So, and the most serious one is our son had some of you know, an adolescence from hell issue with addiction and mental illness. And as a part of his treatment, we admitted him to an inpatient program that specialized in integrated care for co-occurring disorders. And as it happened in this particular place, he got very good care for his substance abuse, but the psychiatry that he got was completely unconnected with his substance abuse treatment, even though it was under the same organization, the same umbrella, and supposedly the same treatment plan. But actually what happened was my son, who is very bright, used the opportunity and his knowledge of the DSM and PDR to describe symptoms that would get him prescribed medications he wanted to experience. So this is to say then that we're all looking in private and public systems for ways for this holy grail of integrated care, but it's really hard, and it's specifically really hard at the level of the providers who are giving the care, and if they don't get it, all of our administrative stuff won't make any difference. In fact, may make things worse. So right now, I think Chuck described the community behavioral health clinics, the health homes. You heard this morning about the whole person care initiatives in the 1115 waiver. They're all different ways, in my view, of trying to do the same thing and finding out ways we can finance and influence the creation of these care coordination functionalities that we really don't know how to do very well. So I'll start with the behavioral health clinics, and I'll hope to end with something that I believe we should all start doing now to prepare for whichever of these things actually ends up bearing fruit that's useful, because I don't believe we know yet of these, whether it's the 1115 waiver, community behavioral health clinics, health homes, which ones are going to be useful. But in some ways, it doesn't really matter, because we, as whether you're a service recipient, which we all are in one way or another, or a service provider, we got to find ways to get this to work. So the nature of the California proposal for the behavioral health homes is that we're trying to address individuals who have complex physical and behavioral health needs, and these are a small subset of the overall Medicaid population, but they account for a tremendous amount of the Medicaid costs. The examples of the potential impact are that if we can affect this properly, we can have huge impacts on things like the number of ER visits and the average lengths of stay. If we get these things right, we may have an effect. If we don't, with the new Medicaid population, we have spiraling costs that aren't controllable. So the goals that we're trying to achieve is we're trying to create a capacity for individualized, recovery-oriented outreach engagement. All of county programs are trying to do this now already. We want to be welcoming, accessible, convenient, culturally competent, and have the capacity to be providing at a variety of service settings. We need to have the sufficient capacity to deliver services to these high-impact populations when they need it and want it, because with these populations, as any providers know, there's the golden moment when people are willing to receive care. You miss that moment, it may be another 2 years of homelessness before that opportunity comes again. The crisis management services need to be available in very unrestricted settings, and they need to be also oriented at not just addressing crises, but finding ways to prevent crises. And then finally, the end, care coordination that allows us to do all of these things. So what we're trying to do is find out, well, where is this going to be done in California if we implement this? So they have to be sites that are capable of providing the array of services. They also have to be able to deal with hotspots, places where these high-risk individuals congregate. I have to tell you, in LA, we have many such spots, and they're becoming ever more visible. And the mental health plans can apply for the certification, but the clinics in hot spots are also encouraged to apply. Now, how are we going to be successful? And this is the difficult part as we're getting ready. We're going to have staffing that is available to deal with these populations and has the right skills, because if we don't have that, it won't make a difference. In doing this, we're going to have the ability to guarantee access for the subpopulation that we are trying to serve, and we can't just cherry pick some of them. We have to have the available to guarantee access for the whole scope. Once again, care coordination has to be a key element, and then we have to provide the full scope of services that are described, and then it will need to be done in such a way that the quality assurance reporting is really clear, because this whole behavioral health home is supposed to prove something. And if we don't get the data that makes it prove something, as Chuck says, then the long-term futures of this are not very good. So what I'm going to talk about mostly is what I think is the approach that we need to take to get this done, and what preparations we need to start doing now, whether any of these things come to fruition or not. And I'm describing that, and some of you have heard this part before, as a health neighborhood. And the health neighborhoods, I think, are an essential part for us to prepare for our future. You know, it is likely, I think, whether we like it or not, that Ron was right this morning, that this 5-year extension of the carve-out is pretty much all we can hope for. And we need to use that 5 years to prepare our systems for ways that we can be competitive and survive into the future. And I think we can and should, because in most places, I think we provide the best high-level care that's available in our public systems here in California. And so that I believe at the high end, we should become and be the dominant care provider in the commercial as well as in the public system, and we should be prepared to market ourselves in that way. And as some of you know, I think we need to, I personally believe we need to overcome the distinction between specialty and mild to moderate care and make sure that our provider networks, the community agencies and ourselves, contract with the health plans to do both, because I don't think from a patient perspective the distinction is sustainable. How are you supposed to know how ill you are before you go where you go? And mental illness being so variable, one day you're in one system, the next week you're in another. To me, it really is a conceptual error that we can fix if we become the provider network for both systems. So I think we need to create an opportunity for our networks of care, our systems in each county, to be the system that does this work. So we're going to have to also find ways that we allocate resources and make sure that we get people into the right level of care. So if we're just, if we're going to live in a system in which we're capitated in some fashion, that means that our full service partnership programs are going to need to work in such a way that people don't stay in full service partnerships forever, but as they achieve recovery, they're able to move down to lower levels of care. And that there should be some kind of common expectation, not for an individual patient, but as a group, that providers are successful in moving people through a system of care. So in Los Angeles, we've been working with our community agencies to develop a levels of care analysis that we can use to construct that, but we're going to need to complete that work and develop that in such a way that we're ready and have those documents ready so that we can compete fully when that time comes. So this will create the levels of care management that we will require to be successful into the future. And these are some of the elements that are a part of that plan that I've been describing. But I wanted to talk mostly about the health neighborhoods. So the health neighborhoods that we're talking about function at two levels. At one level, they're a community change effort, and a health neighborhood is an effort to organize the community so that it uses its own resources to address the social determinants of health. You probably know that if you only had one piece of information that was going to lead you to guess about what somebody's longevity would be, the most important piece of information to know would be not their genetics or their health habits, but their zip code. And in Los Angeles, for example, the difference between the healthiest and the least healthy zip code is 17 years of expected longevity. And so we know that we must address this scandal and find ways of having communities do work so that they can address that. So I believe that our work at care coordination has to be ultimately rooted in a community change, a community empowerment, a community health effort. But the health neighborhoods also operate on another level, which is a service coordination level. So in Los Angeles, and I know this is happening other places, we have worked in 12 different communities in which we have created memorandum of agreement between the mental health provider, the primary care provider, and the substance abuse providers that serve particular communities. And that memorandum of agreement is one to create common treatment plans and share information to work on common clients. But the most important thing is that we're hoping to get, and we're starting to get, these care coordination collaboratives in the 12 communities we're starting with to become members of the health, neighborhood, community empowerment efforts that have already been started in those communities. Because we chose these communities because they already had a pre-existing health collaborative that was either funded by First Five or funded by the California Endowment. So because the community organization efforts take a 5 to 7 year timeline to get operational, we don't have that time. So we built on things that were already there. So our health collaboratives are joining these community collaboratives, and we're going to be offering them innovations money from the Mental Health Services Act to focus on trauma-informed care. And we're going to let the communities choose what they want to do. Is it youth violence? Is it postpartum perinatal depression? Is it help to caregivers of people suffering from Alzheimer's? The community gets to choose. And then two things happen. That social determinant gets a little bit better, but more importantly, there is created a social capital in that community that makes that community healthier. So we've come to believe, and actually we have gotten support from the health plans that serve Los Angeles County, HealthNet and LA Care in particular, to invest in this health neighborhood collaborative as a way of addressing the population health in these communities and move forward, ultimately, we believe, in reducing the bad health outcomes in those communities. A new step that we're just starting is we're trying to engage the county physical built infrastructure departments in this effort. So the parks, public libraries, public works, regional planning in these efforts. And so we've chosen 5 communities that are 5 because of obvious county reasons. 5 communities that we're going to focus on first, in which we will not only do the community empowerment and also the health collaborative, we'll also add the built environment. And we're going to focus on areas like in South Los Angeles, zip code 90044, which is the area that has the worst health outcomes in our county. So those are the kind of efforts that we're trying to start at the grassroots, and then upon those foundations, we ought to build on the health health homes. So each of those communities and those collaboratives should sponsor a health home, and we're hoping also that some of them end up being certified as behavioral health homes as well. So I'm believing that this effort at community empowerment and the health collaboratives ought to be the foundations upon which we add any of these things, the 1115 waiver, the health homes, the behavioral health homes, whatever actually ends up working, that we're ready to implement because we've already built that community foundation. So that's a picture of what our health neighborhoods are supposed to be. Oh, and also in keeping with some of the comments that happened earlier today, in our health neighborhoods, we found the faith communities to be a really important part of the building of these health neighborhoods, and a really good way of getting community buy-in and participation as we built them. So our our faith outreach is really tied in very closely to the development of the health neighborhoods in the 12 we're starting in at first. And ultimately, we believe this is the way to integrate care in all of our communities, but that's a long road. Oh, I already said that. Finally, we also find that the health neighborhoods are a really good way of finding ways of involving people with lived experience, because in our county systems, in our community agencies, we can only hire at this point in time so many peers. I mean, we hire a lot, and some of our community agencies as a proportion even hire more, but everyone needs an opportunity to be able to give back if they're going to maintain their recovery. And so one of the things that the health neighborhoods do is they create a venue for other organizations, faith-based organizations, to sponsor and find good things for peers to do as a way of giving back to their community, which not only increases their well-being, the community's well-being, but it also prepares for future full-time work. So we believe this health neighborhood opportunity, the health neighborhood, as we're thinking about it, is a way of integrating a lot of things that are important to all of us in this room. The faith-based efforts, the care coordination efforts, the peer engagement efforts, and most of all, a way of finding an integration for people that really makes sense and makes their lives better. Health promoters too. Thanks. So now we're interested in questions, but maybe even more than questions, than in comments and views about how we might move this care coordination and integration of care in a sensible way, move that forward. Karen?
I don't know who's facilitating this, but talk about CFR 42. So it's very restrictive with being able to share information unless you have a signed consent form. Have other states found ways around that in order to share information?
So I'll tell you what we did with our county council is our county. So the question is 42 CFR that usually prevents substance abuse programs from sharing anything with anybody, anytime.
Unless there's a consent.
Unless there's a consent.
Very important point.
So that is the key issue, is that in our collaboratives, we've developed a common consent. And that common consent, in the opinion of our county council, doesn't have to be renewed at every single instance of communication, but provides an umbrella for the whole communication. Whereas there have been some interpretations in the past that each individual communication needs to be separately consented for, which of course is not sustainable. But with that common consent for the umbrella of sharing, our county council said that's okay, and that's what's embodied in the MOU, the signed MOUs we have between our providers.
The only thing that I would add is that SAMHSA is working on further regulatory guidance around 42 CFR. And I think the biggest place that we find it causing problems is related to electronic exchange of information, where you can't, the way the HIEs are established right now, you can't track when a new provider becomes associated with a person and when that consent was signed. So just it's kind of makes it it's very clunky, and I think that's one of the things that they're hoping to address. Well, and then Tom, yeah.
Just to follow up on Karen's question, then, as we move into being drug Medi-Cal providers, whether it's a county operated or contracted, so that actually that same approach would work then?
I think so.
What you're describing?
That's the manner in which we're hoping to proceed. So Karen, this is the issue is our goal is that we would like all of our short dwell Medi-Cal mental health providers, adult and transition age youth, to consider becoming drug Medicaid providers so that when people go in, they can get whatever they need, and then we figure out the billing on the backside of it. And there has been some fear that if we hold, say, one of our directly operated clinics out as a substance abuse provider, then the 42 CFR will not only apply to the substance abuse transactions, but also to the mental health transactions because they're happening under the same roof. So I'm hoping that it doesn't go in that way, and we're trying, oh, good,
I don't
Chuck.
think so.
So, but anyway, that's kind of the fear that Debbie was addressing in her question is that, but, sometimes I think 42 CFR is like HIPAA. It has its real requirements and then its penumbra of fear in applications that because people are afraid it might apply, then it does apply, and then you don't do anything as an excuse for keeping things exactly the same. And so I think if we get smart attorneys to interpret it the way we want them to,
Right.
we'll win.
But I think the other important thing is that you have a consent form, right? And most people consent to share their information. And so I think, it's not that you can't share information. You can't share information without consent. And now I'll say the non-PC thing. And if this camera wasn't on me, what I would say is that, do you know anyone who's ever been prosecuted for violating 42 CFR? Think about that. Tom?
So, Marv, you began the talk about health neighborhoods with a really nice slide about social determinants, which are obviously a complex interplay of a lot of different factors. Could you give us an example of organizing a health neighborhood that rippled so that it wasn't just about health services, but it ended up affecting and improving services related to employment, and housing, through the manner in which law enforcement interacted with the community, et cetera, et cetera.
Yeah, so that's a really good question, and also illustrative, I think, of a really important learning for me that took place in the process. We've been talking, so the question is, are health neighborhoods restricted to health issues, or do they really get at the broader social determinants that may be affecting a community, like policing and so forth? And when I started to talk and our department started to work on health neighborhoods, almost all of the energy was coming from the mental health system, and we were moving forward and, dragging partners in as best we could. And then we had a meeting in which we brought in the public health people, and I found out there was a whole bunch of things that public health was doing on a population-based basis, things that affected our clients that I didn't even know about. So one of the first things we did is to make a regular connection between the regional mental health person and the regional public health person so that they could work on common things together. Then learning on those kind of things they were working on, gardens, food deserts, all of those things, we tried to bring that conversation in. Meanwhile, We also working in South LA with Community Partners in Care, which is a much broader, it's a community intervention on depression that UCLA and RAND sponsored. And so we learned from that project about engaging community resources like barbershops and sports clubs as a way of intervening in depression and bringing those participants into the discussion. And from that, an example, the policing example came in. So at one of those discussions, community members were talking about the dead body that was there on the sidewalk and that was just sitting there, and people from the neighborhood, kids from the neighborhood were there with this body with the yellow tape and all of that. And knowing the effects of trauma and the fact that somebody just witnessing a shooting or a scene like that has poorer life expectations than their next door neighbor who has the same demographics but didn't happen to be there to see that shooting. So out of that came a request for trauma-informed care. And maybe even, and we haven't gotten this done yet, but maybe even we should not be providing the trauma interventions, but we should be training the community resources so that they themselves can help themselves by providing those trauma-informed interventions. So that's kind of the way it's unrolling.
Specific to his system, that they have one treatment plan for physical health, mental health, substance abuse. I know my staff would love that. What do you guys think of that? And do you ever envision a time long after you've retired when the public entities would have that?
So actually, we're a partner in that system. So the mental health record that is integrated in that is our record. So it's like, yeah, we're a partner in that. We're trying to learn from that so to make it more broadly applicable. But and the way we've been able to do that is that NetSmart with its Avatar product is the one that we're implementing our directly operated clinics. It's the same one Al is using at Tarzana. And so that gave us the opportunity to use their care coordination module in a really aggressive way. And so for that population, we're using that as an experiment to see how we can move this forward. So yeah.
And let me just say, if Dr. Manderscheid this morning looked at that grid that rates the kind of levels of integration that is on the Center for Integrated Health Solutions website. Having a common treatment plan, common treatment goals, is kind of part and parcel of that. And I would just want to take this a little step further too, especially just picking up on Marv's comments earlier about separating out mild to moderate from serious. I think one of the challenges we have is that we've built a system that when you come into care, we want to know everything that ever happened to you since you were born, and we don't know you. We want you to tell you. We want you to tell us all of these things that we don't use in any significant way in forming a treatment plan or an intervention. And I think as a system, we've got to think about that. If you go to your primary care provider, they take the minimal amount of information that's necessary to initiate treatment, and as they get to know you, that picture gets filled in and the treatment plan evolves, as opposed to us doing a research study to initiate care. So I think that's something that we want to think about, that why do we need to collect all of this information? But those can change, right? Yeah. Well, and I would say two things about that. One, as we've gone around the country and looked at this, if you actually do a compliance grid of what you're required to collect, looking at your state mental health, your state Medicaid, any accrediting body, if you do a grid of everything you're required to collect, and then the average organization, what they actually collect is usually 2 to 3 times more. You're collecting more information than anybody is requiring you to do. So, ma'am.
Things that we never hear about in these spaces is structural and institutional issues, they're just gonna be another approach, another program not getting the success it needs. And I know everybody says it's all over, but there's a lot of things that's all over that has to change in order for all the communities that we serve to be healthy and continue to just thrive. And so we don't talk about structural institutionalized racism a lot, especially, like I said, in spaces like this and in the structure. And when I come to places and see government entities that don't invest in diverse workforce, and we see the same faces, that tells me that there's something missing about us really providing the type of service delivery that we say we want to do.
So I'll answer in two parts. First part is,
Repeat the question.
well, the question is, among African American communities, the health outcomes, even for middle-class people, are worse than they are for majority population. And so some of the outcomes that we're seeing are the result of institutional racism that provides lesser either access or attention to care to conditions that from other people might receive more attention to care. Is that a fair summary?
Along with stress of racism.
Stress, and the stress created by racism. So, so my entire knowledge of this is something that was on NPR a couple days ago, and where the health status of African American males treated in the VA system, where the quality, where the access to care was the same as everybody else, the longevity was better than it was for the majority populations, which reinforces your suggestion that part of the problem is a lack of attention to conditions in minorities that or access to care that in particular communities that are not a factor when everybody gets the same care. So, and then the second thing is, I know in my county, and I know in many counties, there is a very strong effort to increase the cultural awareness and competence of the workforce, and that includes using our Mental Health Services Act funding opportunities to provide scholarships for people with linguistic and cultural needs that our system needs, number one. And number two, people who have a willingness to work in high impact communities where those services are particularly needed. So I know many counties are working very hard to increase the workforce to be able to do that. And we also find that the promotoras and health promoters are also a means to begin to address that problem on two levels. The indigenous health workers have access to community that professionals may not, and then those indigenous health workers are often motivated to become professionals over time. So those are some of the things we're trying to address, that very real problem that you're describing.
We're a small program, small county, and we're integrated behavioral health. And talking about what people say you can't do with 42 CFR, we had our electronic providers trying to tell us that you can't have a shared treatment plan because your mental health people will see your substance use. And what we did was we created a consent for treatment form that the first paragraph says, I understand that I am entering an integrated behavioral health treatment program, which means that staff providing substance use services and/or staff providing mental health services will have access to your records to the extent that is necessary to do their jobs. And then Linda Garrett, who's an attorney for risk management services and is contracted through CSAC, I think, and she comes to a lot of the smaller counties and provides the 42 CFR and HIPAA training. I sent it to her and said, will this fly? Does this get us past needing to keep it separate or having them sign a release that we can talk to ourselves, basically? And she said, absolutely. So, and we've had no problems with it. We've had it audited. And so it was a very quick fix. So where you are integrated under one roof, whether it includes physical health or not, I think there are some really easy ways to deal with that. When we first started doing some primary care screening in our behavioral health program, we thought we would have clients like, no, you can't take my blood pressure, I'm not going to step on that scale. So we tested it with a little questionnaire the first few weeks. We got 0 negative feedback. We got feedback like, this is wonderful that you care about my physical health. And I didn't know I had high blood pressure, and the nurse said she was going to help me, connect to a primary care provider so that can be monitored. So I think that we make things more complicated than they really are.
Amen.
Northeast County.
So that reminds me, early in my tenure, the health director in LA County and I wanted to look at the high utilizer population who had most used emergency rooms in the mental health system, and found out that county council said we couldn't look at each other's records. So what we did is each of us deputized the other as a member of the other person's department, so we could so we could review the records together. And then we found out, in looking at the top 100 utilizers, 92 of that top 100, and these were just mental health and emergency room records, 92 of the top 100 had substance abuse issues on their presentation. And we didn't even access, for obvious reasons, the substance abuse records, but those were the health and the mental health records.
And we have an integrated behavioral health treatment plan and diagnosis form and, throughout our electronic health record.
Kind of going back to the social determinants question, and when you answered, you talked about how you make connections between, with public health and other stakeholders. Is there anything that can be done to increase the relationship between the health world and the criminal justice world, so that people are getting connected to health homes prior to being released from incarceration, or potentially even being diverted from incarceration into health services?
Yeah, so I think the best person to talk to about that is Al, because actually that he does specifically that for all of those things. And in Los Angeles, we're also involved in a very vigorous diversion effort these days, and part of the diversion effort is aftercare. And what we're hoping to have evolve is that the discharge plan of an individual from our county jail would include a referral to the health neighborhood that is operational in the community to which they're returning. And that referral would be first to the primary care physician, because some of the data we looked at shows that people who connect up with the primary care physician first have a better recidivism rate than those who go to a mental health clinician or to a substance abuse provider. So we're hoping that and a lot of people coming out of jail, frankly, the last person they want to see is a substance abuse intervener or a mental health clinician. So if we can get them into the health provider, and the health provider can then provide the linkage to the mental health or substance abuse person they need, then in the context of the health neighborhood, we link them up also with the faith community that they may have interest in, or a sports club, or some different way of using their time than however they were using it before. Because if the goal is the prevention of recidivism, then that change in life cohort is more important than the mental health, substance abuse, or the physical health treatment. Not that those other three aren't necessary, but finding a new lifestyle is the most important thing. And so And we don't know really how to do that yet. And another thing that we're just starting to look at is the brute physical effects of trauma. In other words, a lot of our people coming out of jails and institutions have traumatic brain injuries, and those traumatic brain injuries influence their ability to control their impulses. And yet there are technologies that are available for neurological training that allow people to establish a different mechanism for frontal lobe control, even though the one that they originally had got damaged. But I don't think that technology has been thought into our systems yet. And I think that's kind of like the next frontier. How do we use proper neurological interventions and link them in to the substance abuse and the mental health care that we're trying to provide?
Back to the question of inequities. I was looking at research. They're finding that health homes do indeed, for people who get into health homes, this is patient-centered medical homes I'm talking about, do indeed it does reduce inequities in outcomes for people who are in them based on race and ethnicity, but that there are still significant disparities in who accesses those patient-centered medical homes. So there's that risk of the perpetuation of inequities due to, having these good services that would reduce them, people get them, but there's all these other challenges. So the health neighborhood then seems to be trying to address that. And in LA, you've done a lot of good work with the culturally specific integrated service model in your innovation funding. Can you talk a little bit more about what you have found in the ISM, those culturally specific integrated service models, and how you're weaving them or thinking of weaving them into the neighborhood model to help address that potential risk for perpetuation of inequities?
Yeah, so the one I think that is most robust and easily talked about in that regard is for the Latino community, we did prometoras as the way, and so we trained either existing health prometoras and mental health practices, or created people with lived experience and trained them in mental health interventions. And as we did the outcomes for that, they were fabulous. And the outcomes happened at two levels. One, in terms of the functionality of the patients that were worked on by the prometoras, but even more in the life experience and life chances of those who became prometoras. So we're trying to build that into our health neighborhoods, that there is a role for these health promoters. An example of one of the ways we're doing that, in one particular community, we worked with a Catholic church that already had a pretty engaged health ministry and had some health promoters already on board. So we did a 40-hour series of trainings, 3 hours a night for 13 weeks on mental health first aid, on emotional, whatever actually they wanted for this group. And so I went to the graduation during the summer, and there were like 58 people who graduated from this program. And in some cases, they were persons with lived experience. In one case, it was a father, mother, and their 20-year-old son that participated. And then they do outreach in the community on those things that they have learned. So it was a remarkable experience. Then 2 weeks later, we had another similar thing in the San Gabriel Valley for the Tzu Chi Foundation, which was a Buddhist adaptation of this same effort. So they graduated, get trained, and do that work. So those are some of the examples of that one ISM, about how we learned from it, we valued it, and we're trying to build it into our overall system now. One more question?
Yeah. I'm a physician, so this may sound a little medical model-y, and I apologize. But I've drawn the comparison, I've been talking within my own organization, between how I see primary care delivered in not only just in safety nets, but pretty much across the board, and the standards that we uphold in behavioral health care. And the threshold to be a behavioral health care provider in a safety net clinic is essentially a master's degree. We talk about promotores and peers, but, and those are new concepts, and I'm glad to see those introduced. But the threshold to become an employee in a behavioral health clinic has essentially been a master's degree. And if you look in primary care, you have a number of medical assistants, LVNs, and, we in Alameda County, we're looking at, bringing on board some care coordinators, and I actually had to fight the battle that, we don't want to make a master's degree or a bachelor's degree, a threshold for bringing an individual into our service delivery system. We want to exclude medical assistants and LVNs. And I think that allows, you end up with a care delivery system that has the potential to reflect more of the population that you're serving. If you open up, the doors to a wider variety of care providers, and I'd like to see behavioral health care start to enlist medical assistants, LVNs, psychiatric technicians.
Yeah, we do to a pretty, in Los Angeles, for example, we have a lot of bachelor's level people. Weirdly, their job title is medical caseworker, and then we have community workers. And our problem is really not bringing those people in because we really rely on them to a great extent. The problem is creating a career path through the system for them so that they don't get in a cul-de-sac where they can only go so far and there's no hope of promotion. So, and building that career path in a civil service system has been the really challenging thing. You take 3 steps forward and then take 5 steps back. It can be difficult, but we try.
I would just say that I think in most parts of the country, master's degree is not the requirement for entry. In fact, the predominant workforce is bachelor's prepared or less. All right. We're happy to stay. It's the end of the time, but so you guys can do whatever you want. We're happy to answer questions.